So this formula basically summarizes, right, what affects oxygen delivery. But remember, so I can divide based on this, we know the patient can have ischemic hypoxia, right? So if there's no blood flow, like shock. So in that case, there's every other thing is fine, but there's no blood flow. The heart is not pumping blood, it's not circulating. There's occlusion, right? Yeah. One of the tests that we use to determine if the cause of low oxygen delivery is ischemia is what is SVO2 and CVO2. SVO2 and CVO2 are what? They have venous oxygen content. Venous oxygen content, right? If a patient has low oxygen delivery to the tissue because of low cardiac output, what do you think the tissue will do? So I'm not perfusing the tissue. I have oxygen in there, right? The oxygen content is fine. Hemoglobin, hemoglobin saturation, pH is okay, but the flow is decreased. What would the tissue do to compensate? What do you think, Ross? It has ischemia. Content is fine, problem is CO2. What do you think the tissue will do to compensate? They are going to, okay, right. Now we're thinking, very good. So if I decrease cardiac output, that's why I don't have oxygen delivery. Now I'm going to map. Map is low, there's no oxygen delivery. Actually, you're going to see what? Constriction, though. TPR, to compensate for low CO2. You're going to see, what's the name? Kidneys will compensate with RAS, constriction. However, the tissue themselves will do what? They're going to increase oxygen extraction. Does that make sense? I'm not delivering enough oxygen to the tissue. What will they do? They're going to be taking out more than they usually do. They're going to be taking more oxygen from the arterial blood. More extraction of oxygen. If they're extracting more oxygen, how much oxygen will remain in the venous end? More oxygen remains in the venous end if tissues are removing more oxygen from the arterial end.
Less blood.
Less blood. Yes. So if I see hypoxia due to ischemia, shock, heart failure, blah, 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 vessel occlusion, you check the venous blood. Venous blood is low. Venous blood is low. Right, the venous oxygen rather is low. It is, which tells me that there's increased tissue extraction. That patient has what? Ischemic hypoxia. Whereas like hypoxia, SVO2, CVO2 is low, which is the oxygen, venous oxygen content or saturation, which means there's increased extraction of oxygen by the tissue. The cause is what? Is low oxygen, right? Delivery. And of course, my hemoglobin will be normal, saturation will be normal, PO2 will be normal, right? Because the problem is just ischemia. Nothing wrong with oxygen content. If the cause of low oxygen delivery is what? Is low hemoglobin concentration, that would be what? Anemic hypoxia, right? So in that case, they're going to give you CBC and I see anemia, low hematocrit, low hemoglobin, bringing anemic hypoxia, right? So now you go to anemia, hematology. What's the MCV? What is the, right? You have what the type, micro, cytic, nomocytic, or whatever, and then you're going to specifically determine what is causing right that. Of course, if it's anemia, my CVO2, SVO2 will be what? Will be normal. Saturation will be normal. PO2 will be normal, right? If it's saturation issue, like carbon monoxide poisoning, now my SaO2 will be low. That is arterial oxygen saturation or hemoglobin saturation will be low. So carbon monoxide poisoning will have that. But what happens to your CBC? It's going to be normal, right? My PO2 will be normal as well. Might be normal. Yeah, it's going to be normal. Sorry, it's going to be normal. This is 3, right? 3 doesn't affect 2. Yeah, 2 affects 3, 3 doesn't affect 2. Good. So saturation will be low. SO2 will be low, carbon monoxide. SPO2 will be normal. Remember, pulse oximeter cannot differentiate between carbon monoxide and oxygen, right? So it's not a good marker of carboxy hemoglobin, right? So it's going to be SO2 that would be the best to confirm which has carboxy hemoglobin. So that would be low, but SPO2 cannot differentiate between carbon monoxide and oxygen, so it doesn't help. Yeah, so carbon monoxide is what you're going to see. And then if the cost of low oxygen delivery is what PaO2 is low, That's hypoxemic hypoxia. Hypoxemia. PO2 is low. What happens to my SaO2? It's going to be low as well. 3, this is 2. 2 can affect what? 3. Yeah. 2 can affect 3. So if PO2 goes down, then SaO2 will be low as well. Saturation will be low. I can't load oxygen, right, onto hemoglobin as well. Then I'll not try to find out what's the mechanism of what hypoxemia. I want to see if it's just problem with what cardiorespiratory interface, or is there a problem at 2 or at 1 respiratory system? So air and the lungs respiratory system. So, and then you can now see the A gradient, or look at the overall picture, just kind of see what that difference is, right? If them apart, about that soon. But this is that thing. So this will be your objective. Patients are hypoxemic all the time. What mechanism? They're going to give you these labs or the story, right? Just to you. So interpretation will be important to kind of figure out where is the problem. Basically, is it flow or content? Content where hemoglobin, hemoglobin saturation, PO2 is flow, right? Ischemic hypoxia, right? The others will be normal. Yeah, that case. Then I can also use it to predict compensation as well, right? If a patient has hypoxia from maybe low CO cardiac output and flow, then I'll probably compensate with high hemoglobin as well as maybe high PO2, right? Hyperventilation, get more oxygen to the lung, get more into the blood, right? PO2 will be high. Patient has a problem, hypoxia because of anemia. How they had to compensate tachycardia, right? Cardiac output increases to get more flow to the tissue. Basically, patients hypoxemia because of what? Because hypoxia rather, because of low oxygen content. I'm going to increase cardiac output. They had to compensate. Tachycardia, blah 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 blah. Right. Patient has low cardiac output because hypoxemia because of low PaO2 or low saturation. I can increase what? Hemoglobin concentration. This is what kidney comes in, right? Erythropoietin goes up. Hemoglobin goes up, right? To compensate for low PO2 or low saturation. So you can, yeah. So I can predict the cause. I can also kind of predict the compensation expectancy based on where the pathology is. There is cytotoxic hypoxia, right? Last but not least. So this is where, like cyanide. Cyanide will be cytotoxic. Cyanide inhibits what? Electron transport chain. So in this case, the problem is not oxygen delivery per se. The problem is that what the tissues cannot use oxygen. So oxygen is delivered, but tissues cannot use it because the electron transport chain is what is shut down. Complex 4 is inhibited by cyanide. So in this case, patient basically everything will be fine. My PO2 will be fine, SaO2 will be fine, CBC will be okay. There's no evidence of what is ischemia, or the patient has lactic acidosis and all that. So they are hypoxic. Look for risk factors for cyanide, maybe nitroprusside use. Patient was rescued from a burning building, firefighter, things like that. Yeah, tissue or cytotoxic, right? Hypoxia, in that case. So that's that. Any questions on this? Any questions on this? Oh. Okay. This curve is familiar, right? The oxygen dissociation curve, right? Yeah. Also, this is another way we can compensate for hypoxia, basically, right? Depending on, so if hemoglobin is fine otherwise, but we're dealing with saturation issue, we're dealing with PaO2 issue, the body can compensate, right? Ischemic issue, yeah, we can compensate by not just increasing hemoglobin levels through EPO. Hemoglobin can change the affinity, right, to oxygen appropriately to kind of deliver more oxygen, right, to compensate for the hypoxia. So as long as hemoglobin is fine, or it's not the cause of the hypoxia. On the other hand, this is another way hemoglobin is helping cause hypoxia as well, not just by lowering the concentration of hemoglobin, by holding on to oxygen too strongly, right? That can also lead to what? Yeah, this. So where do we want to be on this curve? In cases of hypoxia, not directly linked to hemoglobin, this curve will be shifted what? To the right. I want to shift the curve. So the blue is the middle, normal, or baseline. I want to shift the curve to the right. How do we do that? Anything that encourages what the taut state of hemoglobin, right? TAUT. It's like the tight. So hemoglobin has this pocket for oxygen. If it's tightly bound, right? If the pockets are tight, right? Oxygen will jump off, right? Easily. If the pockets are tight, so oxygen will jump off, right? Easily in that case. So this will shift the oxygen hemoglobin saturation, right? So hemoglobin affinity to the hemoglobin affinity will be low. So that shift the curve to the right? So conditions that can use what carbon dioxide. So CO2 itself, we call this Bohr's effect. High CO2 levels will increase what will decrease hemoglobin affinity for oxygen. This is a good thing. This happens at the tissue level. So at the tissue level, you want to drop oxygen, you want to pick up CO2, right? So CO2 will be high at the tissue level. CO2 can bind to what? To hemoglobin and encourage, it's going to bind to beta globin chain and encourage what the taut state. Also, CO2 can combine to hydrogen ion, which will do what? Also bind, right? To hemoglobin and encourage the taut state. Yeah. So that will allow hemoglobin to drop oxygen easily. That's smart. So Bohr's effect, right? High acidosis or acidic level will increase with low affinity as well. 2,3 bisoglycerol binds to beta globin, low affinity. High temperature will increase CO2 production, right? Increase hydrogen ion concentration. So that also right shift to the right. Exercise can do this as well. Yeah. High altitude will do this by increasing 2,3 bisoglycerol. Right? Hypoxia will do this, right? Want to compensate. On the other hand, opposite of all this, we would encourage a relaxed state, right, and shift the curve to the left. The patient will have what? A higher affinity, right, for oxygen. The hemoglobin has higher affinity for oxygen, and they're going to hold on to oxygen much more tightly, right? And that's bad, right? In this case, so we don't really want this. So you're going to see this with this condition. And the fetal hemoglobin 2 is on the left side because fetal hemoglobin has gamma chain, right, not beta chain. It cannot interact with 2,3-bisoglycerate. It's good in utero, right? For this, it means oxygen will go from the mother side to the baby side of the placenta. But after delivery, we don't want this either. This can lead to hypoxia. Yeah, in this case. So this we should know. Know the Bohr's effect, right? CO2 affecting oxygen delivery. And there's an opposite of an opposite of Bohr's effect called what? Alden's, right? The Alden's effect. Alden's effect happens in the lungs, not the tissue. Bohr's effect happens at the tissue level. Alden's effect happens at the lungs. And this is where what high oxygen decreases the affinity of what hemoglobin for CO2. High oxygen will decrease the affinity of hemoglobin for oxygen, which means when hemoglobin gets to the lungs, right? Of course, it's now want to pick up oxygen. As it's picking up oxygen, then hemoglobin has what low affinity for CO2. It's going to release CO2 much more easily for excretion, right, out of the lung. Yeah. So this is the opposite of Bohr's. So Bohr's at the tissue level, CO2, high CO2 will decrease the affinity of oxygen, hemoglobin for oxygen, while the lungs, high oxygen there will decrease the affinity of what hemoglobin for CO2. That can be released and excreted out of the body. Yeah. So this should. All right. This is a summary of what? Of hypoxemia, right? So we already know hypoxia. So hypoxia leads to low PaO2, small AO2, right? Is hypoxemia. And this is the summary of the mechanism of hypoxemia. Remember what I told you first, we usually use this A gradient to determine what is going on. Is the problem at 1 or the problem is at 2? So if I draw a line here, so I can divide this mechanism into what? Into air and respiratory, right, system. And then we can go below that, we have what? Our cardio respiratory interface, which includes the barrier. perfusion, that barrier, etc. Right? So if my A gradient is normal A gradient normal, which means both capital A and small a are low, I'm dealing with what? Air and respiratory system. So I'm dealing with either hypoventilation, which is respiratory system, tidal volume is low, respiratory rate is low, right? So capital A is low. Or patient has what? Low, patient is breathing in low oxygen air, low FiO2, low atmospheric pressure, like high altitude. Mechanical ventilation FiO2 is low or something, and low PO2, stuff like that. So how will I differentiate? Once I know this is either 1 or 2, and this is the level of 1, right? PaO2 level, remember. So, and that's why their small AO2 is also low. Good. 1 can affect 2. Yeah. So once I know that it's at 1, air, respiratory system, what do? It's ventilation, B, right? B, air. So what do? Now look at, how do you tell them apart? Look at CO2. What will happen to CO2 levels if I'm hypoventilating? I'll develop what? Respiratory acidosis. So if I see normal A gradient, respiratory acidosis, I'm dealing with what? Hypoventilation. Patient is also retaining CO2. But if I see the air quality, the problem is the air quality. If the reason capital AO2 is low is because of the air quality, FiO2 is low, atmosphere or high altitude and stuff, the compensation will be what? Increased respiratory rate, right? The respiratory system will compensate. So if air is the problem, respiratory system will compensate by what? Hyperventilating. So what happens to CO2? I'm going to blow off, right? CO2. Yeah. But the problem with respiratory system, ventilation is a problem. I mean, air doesn't change, right? It's constant. So my CO2 will accumulate. I'm not going to blow it off. I'm going to blow it off. But if the air is the problem, respiratory system will compensate by hyperventilating, and then that will blow off CO2, right? And you're going to see low CO2 level. So that's how you solve similarity between 1 and 2. Then let's go down. Patient has hypoxemia. A gradient is increased. So that tells me automatically what? 1 is fine. So forget air, forget respiratory system, forget ventilation. Focus on what? Cardiorespiratory interface. The problem is a level of what? 2. PaO2, small AO2. Capital AO2 is fine. So now I'm thinking what? It's a what? It's a mismatch. So lung is ventilated, but what? It's not perfused. I'm not getting blood there. Or I'm perfusing part of the lung that is not what? Ventilated. There's problem with the cardiorespiratory interface. Or shunt. I'm taking blood away from the lungs. Blood is not going through the lungs, through the alveoli. Shunted away, right? Or something's wrong with the what? Barrier, perfusion barrier. So you can see, right? So ventilation doesn't match perfusion. There's the interface, something's wrong. The barrier, or also perfusion, right? The shunt, shunting blood away from the lung or from perfused part of the lungs, right? So now I forget air, I forget ventilation, focusing on what? Those BQ mismatch, shunt, perfusion impairment. How do you tell them apart? In all of them, okay, so all of them will compensate with what? With hyperventilation, actually, right? All of them are going to some hyperventilation, blah, blah, which makes sense because there's nothing wrong with one. One will compensate. But remember, our saturation will definitely be low, right? All of them, SO2 will be low because PO2 is low and stuff like that. Then you might also see maybe hemoglobin can compensate. Hemoglobin will be high concentration-wise. In all of them, hemoglobin can also be shifted, right? The curve will be shifted to the right, so I can release oxygen much more easily, right? You're going to see all those compensation there. Yeah, but then SO2 will be low for sure because PO2 is low. Now, how do you tell them apart? This is what you do. You look at oxygen supplementation. So for these three, if I give the patient oxygen and there is no response, PO2 still remains low. I'm dealing with what? With a shunt. I give oxygen supplementation, PO2 is still low, there's still going to be, it means there's a shunt. In other causes, including VQ mismatch, division impairment, even if it's a hair or respiratory ventilation issue, if I give oxygen, you're creating what? Greater gradients. And there'll be more diffusion and it can correct PO2 a little, where PO2 will rise somewhat, it's going to respond. But if there's no response at all, they're dealing with a shunt. blood is bypassing the lungs, right? Completely. That's the problem. Or the alveoli is completely what? Filled up. So if I have my alveoli, they're filled up, right? Completely filled up with fluid. Oxygen, even if I give oxygen, right? Oxygen can enter. There's nothing there for the oxygen to fill. If oxygen doesn't enter, right, there's no way it can get to the barrier, right? Nothing happens. Or if the alveoli actually perfused, but I'm sorry, they are ventilated. Air is here. There's air here, oxygen, but the blood flow. So let's say there's a pathology that is bypassing, right? So blood is shunted away through another vessel, right? Away from the alveoli. Which means if I give oxygen, what happens? There's no blood to pick up. There's no blood flowing through the alveoli to pick up the oxygen. You won't see any response. PO2. Small O2 is still low. If I give oxygen. So now you're dealing with shunt. In that case, something is shunting blood either away from the lungs. So we're dealing with from the alveoli, we're dealing with intrapulmonary shunt, like AV malformations. We're dealing with intracardiac shunt, right? Remember our right to left shunt is cyanotic heart disease, right? They're bypassing the lungs, going straight from the right to the left side. Yeah, they won't respond to oxygen. Or patient has pneumonia, pulmonary edema, ARDS, right? I'm filling the alveoli with fluid. Oxygen can't enter. So even if you give them oxygen, right? Nothing. That also creates a shunt in that case. Yeah. So you won't see any response. But in VQ mismatch, diffusion impairment, right? You're going to see some improvement with oxygen supplementation. Yeah. But you won't see that in the shunt. So this is how you tell them how the mechanisms apart, right? From each other. Then let me give you guys examples here. So this is just a table summarizing that. You're gonna get all these notes. So we didn't know. So I'm dealing with hypoxemia. I check my AA gradient. You might be giving capital. You might be giving these numbers. Typically, examiners give you this one, small AO2, right? Because that's how you're gonna know. As hypoxemia, this is less than 85. Or SaO2, which is often known as less than 75%, you're dealing with hypoxemic hypoxemia. Yeah. And then you're going to be given, next step, check your, just to prevent disorganization, right? Be organized. Check your A gradient. An examiner might give you this capital A, right? Directly, or they might not give it to you. This is a quick formula to calculate it yourself. In case you need to, but probably you might not need to, right? If you understand this principle, you might be quickly able to predict what is going on and see clues to the etiology. But sometimes you might need to calculate it, right? So if you're giving, check your differences and see. I usually keep a difference of about 20, less than 20, right? For most people. Actually, in most younger patients can be as low as 12. In older patients, it should be less than 20 overall. So the difference will be definitely significant, from like 30, 40 for you to know, okay, there's a wide difference. If it's elderly, less than 20, you can just see that normal range. Younger patients, less than 10, thereabouts, you can see that's normal range. Yeah, but it's going to be noticeably wide or normal range. So if it's or if you need to calculate capital AO2, right, you can use this formula 150 minus 1.25 times PaCO2. That will give you what the capital AO2 is, and then find the difference. So if it's normal, then we're dealing with what? Air and ventilation, respiratory system, air. Then look for CO2. If CO2 is high, hypoventilation. CNS depression, blockage, obesity, opioid use, things like that. Respiratory muscle weakness, right? If CO2 is low, I'm dealing with what? Low FiO2, low PO2, atmospheric pressure, like that. Then, if my A gradient is wide, then check if there's response to oxygen supplementation. If there's a response to oxygen supplementation, we're dealing with what? VQ mismatch. Classic example here would be what? Pulmonary embolism. Yeah, pulmonary embolism. Exercise can do this too normally, right? But pathology, definitely there's occlusion of the vessel, right? So no perfusion to the lungs. Diffusion impairment, emphysema. Remember, emphysema destroys, right? Lung tissue. There will be decreased surface area for diffusion of gases, and then increased thickness of the barrier. You're going to see that in what? In pulmonary fibrosis. pulmonary fibrosis, there will be increased thickness of the barrier, interstitial lung disease, and then emphysema will decrease surface area. So this will cause perfusion impairment, but PE will cause VQ, right? Mismatch. Then unresponsive, if there's no response to oxygen saturation and oxygen supplementation, again with a shunt, which may be intracardiac. So your cyanotic heart disease, the failure, transmission of the blood vessels, blah, 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 etc. Or somebody with initial acyanotic that has progressed to what? Esen-Menger's syndrome, cyanotic. AV fistula, yeah. So blood is going from the arteries into the veins and bypassing the lung, right? That, right, like subclavian, right? Artery, arteriovenous malformation or fistula, axillary, femoral, right? Those will be bypassing, blood will be going from the artery into the veins and doesn't go back to the right heart, doesn't go to the, no, sorry, it's going opposite, sorry, venous to artery, right? So some for like hemodialysis, right? So chronic hemodialysis can lead to this. Patient has fistula for dialysis. Over time, the veins become as thick as the artery, so the pressure can get reversed. The blood goes from the vein to the artery, right? Now bypass the lungs. You may also see AVMs. There's a condition called HHT, right? Hemorrhagic, hereditary hemorrhagic telangiectasia. What's the former name? Is it the Osler-Weber-Rendu disease? I think. Osler-Weber-Rendu disease. HHT. So patient has these malformations in the throughout the body, right? Brain, lungs, the liver, AVMs, right? These AVMs, if they're in the lungs, they can bypass the capillary, the capillaries that supply the alveoli. Yeah, so patients also have like a shunt. They're going to be hypoxemic. You give them oxygen, there's no response they're dealing with, right? This could also be a cause. If they tell the patient has history of like bleeding, you also see telangiectasia, right? Pinpoint vascular malformations around their skin, the mucosa surfaces, like them with this, yeah, HST, AVMs. There's hepatopulmonary syndrome in patient with liver cirrhosis. Yes, somebody with liver cirrhosis has hypoxemia that doesn't respond to oxygen. It's hepatopulmonary syndrome. So too much vasodilators in the lungs will bypass. They're going to dilate some vessels that will bypass the alveoli and that can into a shunt. Then we have intrapulmonary shunt, also from either AVMs or anything that causes what that fills the alveoli. The alveolar space are filled up with fluid, pneumonia, pulmonary edema, atelectasis, they collapse completely, right? Oxygen can't even go in there at all. So also creates a shunt. Give them oxygen, you see much response, right? So these are our mechanisms of hypoxia, mechanisms of hypoxemia, as well as how to understand or interpret what A ingredient, right, correctly to come